Hey everybody, welcome to Medic Junkies episode 5. Now before we start today's episode, I just want to quickly say thank you to everybody that's been supporting the channel and supporting me in these efforts. I really appreciate it. So as you watch these videos, if you really like what you see, if you could please just hit the like, subscribe, hit the bell. Once you hit the bell, that's going to notify you anytime new training videos come out. And of course, the whole point of these is to get information, new techniques, protocols, just to share stuff to the masses. So please feel free to subscribe, show your support, and thank you. Now, for today's episode, we're going to talk about EZIO. We're going to talk about the protocol, we're going to talk about how to select the right needle, and of course, which insertion site might be better than the other. Okay. Now, to go to our protocol, of course, we're following the Central Arizona Regional EMS Guidelines. This is what your EZIO protocol is going to look like. Now, if we back out on this app to the home page here, we can go to the bottom at resource section, go to EZIO, and here's our app. Okay. So let's talk about when we do an IO. IOs are designed for critical patients. If you show up and that patient is an immediate type patient, okay, they're unconscious, they're a code, we are allowed to go straight to an IO. Now, of course, if you show up on a code and they've got ropes for IVs, it's up to you. If you want to do a peripheral IV, go for it. Okay, but most codes probably have very poor vasculature, and I'm not a fan of digging around for IVs when I need to be slamming drugs, pushing fluids. I don't really want an IV that's going to be a positional IV or maybe a small catheter. I want something big and solid, and of course I need it fast. All right. So if you have a patient who is a code, go for an IO. If they're a critical patient but still alive, you have the option, peripheral IV versus IO. If you stick somebody twice with a peripheral IV, it's time to switch to the IO. So 2 times max, don't mess around, don't make somebody a pin cushion, okay? If you have somebody who's altered with a GCS of less than 8, go for the IO. If they are respiratory compromised, they can't oxygenate, they can't ventilate, or if they are hemodynamically unstable, meaning they're super shocky, blood pressures are tanking, all of those would be reasons that would indicate IO use. Now, a few things that are going to contraindicate this IO is going to be a fractured bone of that insertion site, excessive tissue, so maybe you don't have a needle long enough to get through that tissue and actually get into the bone. If they've had previous or significant orthopedic procedures, maybe like a prosthetic, they've had surgery to the point where they've got rods and pins in that extremity, or maybe you have this patient who was IO'd within the last 24 hours, you can't IO the same site. Okay. Now, if that IO has been done a couple days ago, it's already been removed, and now it's been greater than 24 hours since the removal, you can still go ahead and use that site. They say that's okay. Now, coming down, looking at our location options, okay, for adults, they do prefer to use the proximal humerus. You can also use the proximal tibia or the distal tibia. Now, my personal opinion between the humeral or the tibia is going to depend on the situation. The humeral site, we know that we can push fluid 5 times faster or 5 times the amount of fluid through the humerus as compared to the tibia. So if we're trying to fluid resuscitate somebody, of course the humeral site is going to be our location every time. Now, if we're just looking for rapid IV access, let's say in a code, and we just want access to push our epi right away, I would go for the tibia, especially in a code. Another reason being, in cardiac arrest, you have so much stuff going up by the torso. You've got compressions, somebody ventilating, we're trying to put pads on the patient. There's just a lot of activity. So if you can quickly grab your IO, go down to the leg, you're out of the way. Usually your landmark or your target is much larger in the tibia compared to the humerus. And it's just so much easier to palpate. Okay, so you can find your landmarks quickly, you can get your IO quickly, and you can push your medications much faster. Now let's say maybe you need quick access for drugs and you need to fluid resuscitate. Nobody says you can't drill them twice, so maybe go to the tibia, push your drugs, and then once you get the chance, we can go ahead and move up to the humerus and use that location for fluid. That's going to be entirely up to you as a provider to make that choice. Now in kids, we are allowed to use the proximal humerus, but only if they are 5 or older. Okay, so if they're less than 5, can't use the humerus. We can also go on that proximal tibia as well. And we can also use the distal femur in pediatrics, okay? So let's say you have that 2 or 3-year-old, God forbid they got bilateral tib-fib fractures. You can't use the humerus, you can't use the tibia. Your distal femur is going to be your best bet, okay? And actually, in all the things that I've been reading and researching, the distal femur is kind of preferred in kids because it's pretty solid, it's well developed, and I would think that it's a little bit more central than using a proximal tibia, okay? Now, if you choose that you have to go to the a conscious IO, we're going to want to make them as comfortable as possible, okay? So lidocaine is going to be our preferred medication here. So you would have to, if they're coherent enough, of course, talk to them, explain to them what you're going to do, try to give them some reassurance that this is not going to feel comfortable, but it's necessary for their given situation. Now, once we get the IO, we need to go ahead and give a little bit of lidocaine, and we want to give it about a minute to sit in there and really take effect. And then we can start pushing our medication or infusing our fluid. If we need to give more lidocaine, let's say they're still in a lot of discomfort, you just need to go about half the original dose, okay? Now, if you've ever thought about, or if you've ever done a conscious IO in a little kid, let's say like a 1-month-old, the amount of lidocaine that we're pushing is so small as far as volume goes. So something to consider, if you have attached an extension tubing to your IO, the fluid coming from your lidocaine out of that 1 cc syringe is not going to reach your patient. So you're going to have to push your lido and then back it up with a little bit of a saline flush. Even if you're going straight to the hub of your IO, it's probably going to get stuck within the catheter of that IO, again, not reaching your patient. So consider the amount of volume you're giving. Let's take, for example, this 1-month-old, just to play. So we have a 1-month-old. Now, we got to figure out how much they weigh, okay? The formula for months, anybody less than 1, is 9 plus the months, divide all that by 2, and this is going to equal their kilos. So for that 9-year-old, let's do, or that 1-month-old, let's do 9 plus 1 month divided by 2. Of course, we got 10 over 2, also equals 5 kilos. Now our dose for lidocaine, remember, was 0.5 milligrams per kilogram. Okay, so 0.5 times 5, that's going to equal 2.5 milligrams. Now, how do we figure out how much volume to give them? Okay, take your pre-made lidocaine out of the box, and it's going to come packaged as 100 milligrams in 5 cc's. And we're going to use the bolus formula, volume times dose over concentration. Okay, so our volume is going to be 5 cc's. Our dose was 2.5 milligrams. And our concentration is 100 milligrams. So 5 times 2.5, that's going to equal 12.5 over 100. We're going to move the decimals over a little bit, and that's going to give us 0.125 cc's. Okay, so if we switch over here real quick and look at this syringe, I've already drawn up that 1.25 cc's. Okay, you can see that is barely any fluid. Okay, definitely make sure that we follow that up with a saline flush to actually get it into our patient. Okay. Now, let's talk about sizing. They have removed the pink Pediatric IO out of the protocol, okay? And I'm actually a huge fan of this. I think those pink ones are garbage. Almost every time I've heard of somebody giving a pink IO to a small child or an infant, either 1, it doesn't work at all, or 2, within the first or second bolus, that thing pops out and it's no good and you infiltrate, okay? So I am super happy that they've removed that. These pink ones, get rid of them, okay? So that leaves us with the blue adult IO. They recommend that we use the blue one for 3 kilos up to 39 kilos, okay? And for adults, they're actually recommending using the large 45 millimeter or the yellow IO. Now, if I'm going for the tibia of an adult, I do think the yellow might be a little bit excessive. that thing's going to stick out pretty far. However, all we got to do is just make sure we pad and secure that thing properly. Now, if I'm going in the shoulder, I absolutely recommend using the yellow on an adult every time. Okay, you may even consider using the yellow on a kid. Just depends on how big they are, how old they are. Okay. All right. So let's talk about these IOs again real quick. We have our pink pediatric one, we've got the blue adult, and the yellow large adult. Okay. The diameter of all of these is the exact same. They're 15 gauge needles. Okay. The only difference is of course the length of these IOs. So again, technically we could use this yellow one on an infant. It's the same size, diameter, it's just going to stick out way more, so we'll have to make sure we pad it again. Okay. Now if we have to do an IO, we want to make sure we get all of our equipment ready first. We've got our pressure bag for our IV. If we're doing a conscious, we would need our lidocaine. Okay. We of course need a flush, our pigtail, an IO, something to secure it with, our driver, and this would be another option to secure if you choose to use it. Okay. Now let's talk about how we actually go with our depth. So if you look at these IO needles, there's going to be these little 5mm marks on the needle itself. Okay. So here's our pink one. I don't know if you can see that little 5mm mark right by the hub. Okay. So if we go, and let's say that the first technique when we do an IO is we want to find our landmark, of course. We're going to push through the skin and we want to feel it hit up against the bone. Okay. Now, once you feel it hit the bone, what we're looking for is that 5mm mark to still be showing. Okay. If you can't see that 5mm mark because it's already in the tissue, then your IO needle is not long enough. Okay. We've selected the wrong one. You need to pull that out. Go get a bigger one. Now, if you have not drilled this site yet, we can remove this out, find the bigger option, and you can go through the same hole. Okay. Obviously, you probably want to wipe it off again with alcohol before you do, but use the same hole if you have not drilled. If we've already attempted our drill and punched a hole in the bone, then that site is gone, no more. You got to go to another location. Okay. Reason being, if we punch a second hole in this bone, once we start infusing medications or fluid, it's just going to leak out through that original hole and possibly cause problems as far as necrosis, and of course you're going to have swelling of that site. Okay. So again, like I said, proper technique is we're going to find our landmarks first. So this is going to be representing our proximal humeral. Okay, so we would want to, of course, rotate our patient's arm across their belly so it brings this humeral head more anterior. Now we're going to try to palpate around. You find the humerus, and as we come up, we're going to feel where that ball starts to protrude out. We actually want to go on that most protruding spot of that humeral head. Okay, so palpate, nice and easy there. Of course, we would disinfect our site, and then we would want to take our needle and go right in. Now for the shoulder, we're going to a 45-degree angle, kind of like downwards towards our patient. I can get the camera angle right. So this would be coming at a 45-degree angle. Of course, we go through until we feel it hit the bone. Okay. At that point, I would go ahead and drill. Now, when we drill these IOs, your goal should never be to put the hub all the way to the skin. Okay. We don't want to do, that's not our goal. Now for adults, if you're going, let's say in a tibia, might we get the plastic to the skin? Of course, absolutely, you might. But if that's kind of your goal and your go-to every time, when you go do a pediatric IO, I guarantee if you bury that thing, you're either going to put the end of that needle in the other side of the bone or go completely through and through. Okay, which then of course you're not going to be any good. So when we are drilling, it's all about feel and sound. Okay, you want to let the IO do the work. So as we pull our trigger, you're just going to let it go, put a little bit of pressure on your IO, and you're waiting until you feel that pop or that give, or you can even hear sometimes the RPMs rev up. Okay, so all right, I think I found another hole in there already. There you go. The IO is still going to stick out slightly, especially on the shoulders. That's okay. All right, we're just going to have to really stabilize this site. Now, if you're doing a shoulder IO, I highly recommend that if you have this device, this is what we're going to use, okay? And this device would have to go over the IO first. You peel that wax paper off, stick it, and then we would put our tubing right on top of that. And that's going to help kind of anchor everything all together. If you don't have this device, then you're going to have to use the 2 rolls of cling, kind of sandwich it here, and being on a shoulder, you're going to be throwing duct tape probably in like every possible direction to really hold that in place, okay? All right. So that was the humerus. Clear some space here. Like I said, we're going to palpate, find kind of the flat part of that humerus, walk our way up until we feel the ball and that most protruding part of that humeral head. That's where we want to go at a 45-degree angle. Now what we're looking at here is going to be our distal tibia. Okay, so we might need to bend their leg a little bit to where we can really palpate that tibial tuberosity. And what you're going to do is basically get a finger on it. Okay, we want to go about 2 fingers below it and 1 finger medial. And this would be my location here. If we're going to go in our distal tibia, okay, we're going to find the ball of that medial side of our heel, okay, that medial malleolus. You're going to get a finger on it, and we're going to go about 3 fingers up. And then we would go right here in the flat spot. Now, if we're going to do the femur on a kid, what they recommend is you want to palpate for that patella, okay? And basically at the very top margin of that patella, we're going to go 1 centimeter proximal, which is probably about a finger length, okay? And then they say to go about 1 centimeter medial. So again, it's not right on top of the ridge. We're going to go 1 finger up, 1 finger in on the medial. This is actually really low, really distal on that femur, okay? And you might want to try to bow leg this leg out a little bit, try to flatten it out. And then when we drill, remember we need to go to a 90-degree angle to the bone, not necessarily 90 to the floor, okay? So that way, again, if you kind of bow leg them out, it kind of helps with your angle, okay? All right, so let's talk about the actual procedure here. Again, we're going to gather all of our equipment. Let's say that we're going to be doing this on our infant. Now this is the same size of an adult IO, but it's a training needle, so it's red, okay? So I'm going to grab my IO, I'm going to grab my flush, my drip, or my extension tubing here. Okay, of course I would want to pre-prime my tubing, get all the air out of there. I have something to secure it with. I have my pressure infuser to go on my IV bag. And I would have an alcohol swab, and I would want to clean my site, okay? So let's just go for this proximal tibia. That's what this mannequin's designed for. They don't have a hard bone in the femur. Okay, so I'm going to palpate. We want to go, again, just below the knee. You may or may not be able to feel that tibial tuberosity on an infant. Usually it's pretty hard to feel. So we're going to go about 1 centimeter down, and of course we want to go medial as well, okay? Again, clean my site. I got my IO. I'm going to kind of hang on to my foot. You never want to hold right behind because we don't want to accidentally drill through and hit our hand. So I grab him by the heel. I'm going to first punch through the skin, feel it hit the bone, and then I'm going to go ahead and pull my trigger. And again, I'm listening for it and almost feeling that pop. Okay, as soon as it goes, that's it. Let off the trigger. It'll probably rotate a couple more times to really seat itself. Remove the drill. Now hold the base of the hub. I'm going to unscrew the stylet there. And now I can go ahead and put my tubing on. Now first thing you want to do is withdraw. So as I withdraw, hopefully you're starting to see that reddish yellow bone marrow and blood come up. As soon as you see the presence of that, that's good. You don't have to suck a lot of it up. Just the presence. And then you want to go ahead and give a little bit of a flush, okay? Don't slam it, because especially with little kids here, we don't want to pop it out of the bone. So nice, gentle flush. It should be nice and easy. If you're really struggling, trying to push hard, then you're probably not in the right place. Also, this IO should be nice and solid. If it's wiggling around, you're probably just scraping the surface of the bone. You're not actually in, okay? So this feels pretty solid. We're going to withdraw. We're going to push a little bit of a fluid bolus in there to make sure it infuses well. And now we're going to have to stabilize. I prefer to use 2 rolls of cling here to kind of sandwich it. And then usually I'd have a partner grab some Coban and help me wrap this thing up nice and tight. Okay, so you can't even see the IO once it's all wrapped up. It's solid. Again, if we want to use the other device to secure it, this little triangle device, this would go over the top of it, okay? And then we would pull I guess on this one, usually there's 2 pieces of wax paper. This one only has 1. So this goes right over the top. Okay, this would stick to the leg, and then my tubing comes on top, screws snug, and that would hold everything in place. Okay. With that being said, that's about it. If you have any questions, please comment. Of course, if you know me, you can text me, email me, call me, whatever. But if you have any other ideas, techniques, please share them in the post. And I'm also going to share a couple of links to some other videos that I saw that were pretty helpful in this. So with that, thank you very much.